Good afternoon, everyone. I first want to start out with some of our numbers. As you know, and I apologize to the reporters here, you're going to see as these numbers go up and some of the news of the day that our website, while we regularly post it to, some of that will change as the activity goes and different people announce more at the local level. We receive all that data, but it might not be. So I'm going to share with you what I know as I know it. Right now, for certain, we have 9 males and 5 females. We now have an age range of cases, 34 years to 66 years of age, with a median age of 48. And their illnesses, not the case, because as we know, we started testing. Our first case was, I believe it's been a long week, Monday. But their illnesses started as far back as February 25th and as recent as 3/11. We've had 4 hospitalizations, no deaths. The number of counties with cases, and this is, you'll be hearing more as more and more test results come back today. 6, we have Belmont, 2, Butler, 1, I think there's more information coming there. Cuyahoga 6, Stark 2, Summit 1, Trumbull 1. Again, it's very hard to keep up with these numbers. I'll explain that. Cleveland Clinic did get the ability to test and went live today. So they're actually doing their own testing, which is helping speed this up. And Dr. Wiley shared with me this morning that they can do 500 a day. So that is our first big surge forward in testing. And UC did announce 4 cases, I believe, as well. They have another under investigation, but they're doing a combination of our lab, and they did have, I think LabCorp was involved, a private lab. So all that comes back to ODH, and we'll summarize that and be printing that out. We do have 50 negatives. We have 159 under investigation. So again, we're up operating three testing cycles. Our EPIs are now on, our epidemiologists, our disease detectives are working 2 shifts of 12 hours. I do want you to know when we talk about testing and even some of the drive-through testing that the hospitals are trying to get underway, you must have a doctor's order. Health departments don't do testing. You really need to talk to a doctor, preferably at this point, call them, and they'll talk through this with you. As we see this disease spread, we will know that most of us will hopefully ride it out at home. That's so important. So you'll need to talk to your doctor. They'll decide and do a thorough history with you and decide about that testing and give you instructions on how to do that. So with that in mind, I must say I didn't mean to go viral yesterday in any way, and that has led me to want to give a little bit of a science lecture. For those of you who know, I was a professor of global public health at Ohio State for many years, and I'm going to go quickly because I know it's tiring to stand up here, but I think this is so important. I'm going to do my very best to kind of break this down in a way that's understandable. I want to walk you behind the veil of what's been happening with all of this. I've told you all along that there are, ever since 9/11, there's huge effort on preparedness that goes on at the federal level, at the state level, in my department, and at the local level, and that involves many players. And so we've had these pandemic plans, often based on flu research, and those are all underway. They're there all the time, and we were certainly working ours from the beginning of hearing the first cases in China. And as you've seen, everything, the heroic efforts that the CDC and the federal government are taking. I've said all along that these things are not perfect. I have to keep reminding my own team and myself that if we can get this 80% right, that still makes a huge difference. And if you remember, on that curve, everything we're doing is trying to decrease, slow this disease transmission down. We know it's here. We're slowing it down. We're trying to decrease that logarithmic spread of one person giving to 2 to 3 people and on, so that people stay safer, that we keep you healthy, but also so that our health system can handle the sickest patients. When you are involved in this work, and my colleagues around the country, you'll understand what I mean, as somebody had this famous quote, on the front end of a pandemic, you look a little bit like an alarmist. You look a little bit like a Chicken Little, the sky is falling, and on the back end of a pandemic, you didn't do enough. And that is your fate in my role, and that will be the fate of all of this, because whenever a pandemic has come and gone, or any infectious disease, a preparedness also has an end evaluation. We do a hot wash. We do something called after action, and we look at everything we did and we learn from it. So part of this learning from the past, actually for me, began with the people who actually invented this curve and who actually invented these plans. As late as this morning, I was on the phone with Dr. Rajiv Venkaya, who was actually working during H5N1 with President Bush. And in the White House, they made this strike team of, I believe it was about 7 brainiacs, to begin some of this complex modeling to try to decide how do we react in a pandemic when we don't have any drugs yet. They invented this whole field of staged interventions and community mitigation with many, many colleagues in the CDC, but that's where it all began. But they actually went as far back as the Spanish flu. So, 1918. And it's so interesting, poor Spain, because they did a lot of the right things, but it got named after them. But in this country, and what's so important, because timing is everything, in a 2-week period, one city took dramatic actions, St. Louis, and 2 weeks later, Philadelphia started doing the same actions. And the trajectories for the two cities were widely different. So we know that balancing the right action at the right time is so important. This work, bird flu was it was more deadly than the regular flu, but it wasn't very infectious. H1N1 came along in about 2009. It was spreading more, but it was actually less fatal than the flu. In 2007, there were recommendations made that form a lot of what the CDC is putting out. In 2017, those were looked at again, very famous, and I encourage you all to look at the MMWR from April 21st of 2017. That's a lot of the post-action on H1N1 and what we've learned about flu. But of course, we're in a time where it isn't the flu. This is coronavirus, and every day we're learning something new. And I know that confuses people because, there's multiple conflicting ideas, and experts who do this modeling will differ in how they think it should be done. But by and large, there is a playbook, and we're all executing it, and it's going to unfold in one state here, one state there. It's going to inch its way forward, but that's what you're seeing unfold. When you're a leader making these tough decisions, you have to get the best advice. And all along, when I advise the governor, as does dozens of experts that have been assembled, we give him our best advice with the best information we have, and that has varied moment to moment. But, we work with the government, we work with the CDC, the White House, ASPR. We work with all sorts of disease modelers. But we also work at the Ohio Department of Health. I have 1,100 employees, many of whom are moving through those same step down to work at home today. I just want to say to them, thank you for all you're doing. I'm going to talk to you soon. This has been crazy, but I'll talk to you more about what's ahead for you. But 113 local health departments in a state like Ohio, where we are very decentralized, they have their own boards and own health commissioners, but they're on the front lines with the plan right now. Those are the ones I told you to send the cookies to. They are working tirelessly around the clock, sleep deprived right now. They're working with mayors, schools, all our hospitals, philanthropy, businesses, heavily involved. And then also, they're the ears on the ground. So information I'm taking in is coming from communities. Every doctor I've ever known in Ohio is calling me, telling me, we can't get equipment, we can't get PPE, or I need your help on this. So all of that from patients and their questions coming to our hotline, all of that information we're taking in and charting a course. So what we are instituting right now has 4 simple rules, And it's called, we went from the containment phase where we hoped, with early diagnostic testing and isolation and quarantine and borders, the dramatic moves that the president took to contain it, but eventually we always knew we'd reach mitigation. And this is very important here for people to understand. It's early, targeted, and layered interventions. Early, targeted, layered. And timing is everything. There's also a matter of how severe a pandemic is. And when you look at the guidance that the CDC put out on schools, it goes from what is guesstimated to be mild to moderate to severe. And that impacts the duration of the interventions you put in place. Now, this disease is interesting for several reasons, and it's different than H1N1 in some circumstances. The travel that we do now is different than 2009. Our dependence, we've learned a lot about, and we'll learn a lot more in days to come about, the PPE, where it's manufactured. We will learn a lot about our medical supply. Our communications and our social networking, all of that is a little different, and it's factoring in, plus the fact that our studies are ongoing all the time. So what are these 4 interventions? They save lives, and they have to be implemented together. If you are sick, number 1, if you are sick, stay home. That is isolation for the ill. Isolation equals ill. 2, if someone in your household is sick, and we've talked a lot about households, you stay home too, and you quarantine. So quarantine is for people who might have been exposed back when we had our 200 and some travelers, but it is for people who should stay at home. 3, social distancing and isolation. That is our 6 feet. That is our mass gatherings eventually as this progresses. That is getting us out of socially dense situations where we have rapid transfer, again, 1 person to 2.28 people now on best estimates and onward. These are the individual controls as well. Everything, keep doing it. It so works. The hand washing, the coughing, the not touching your face, which I'm desperately trying not to do. It's hard, I know. And all these things are what matter. Now, last stage, of course, are the things we've taken. School closings, and eventually, if needed, the daycare closings. Those are the hardest, and you'll hear experts debating about this forever on the networks as we speak. And it is because you have to take the risk benefit of it. You have to think about your nurses who have kids in school, and you need that workforce. You're weighing elaborate groups of things, but even in the modeling, they took this into account, and they have what they call cascading consequences. And we're rolling out, we have to move quickly in this case, so we're doing our big rocks, but in the days to come, and just this day, Director Hall, and you've heard about the work she is doing, we will keep layering and layering this response with all the supports that people need. But that is how this works. Now, this is a key point. It's not perfect. Any one of the 4 interventions themselves only does so much. It's like Swiss cheese. Like you have 1 piece of Swiss cheese and you've got some holes in it. But if you layer Swiss cheese on top of each other, if you do it just right, you can cover up a few more of the holes. It gets harder and get through. So you've got 4 Swiss cheeses. You're getting about 80%, maybe. That's a guesstimate. You'll have to live with me on guesstimates in this world. And therefore, you're getting more impact. And as I said, timing is everything because it's a lot like a fire. These non-pharmacologic interventions that stall us and slow us down are like when you have a fire on your stove and you have your kitchen extinguisher, you want to get it quick, and you don't want the fire to get out of control. And so you really want to beat that upward slope of infection. Now that's tricky, and experts are going to disagree, and there'll be postmortems. But when I talk to my colleagues in Washington, they wish they could have done more sooner. And so we're learning from Italy, we're learning from some of the data we're seeing around the world. Interestingly, kids are getting infected. There's one study, I just want to mention this, Japan, because of the Princess cruise ship, that was the one place they actually tested kids, and they found that there are amplifiers. They get infected just as much. They don't get as sick, but they do, and that's why schools and the nasty stuff you were mentioning are important. Now, you can also go too soon, and so it's a delicate balance, because if you go too soon, you exhaust people of doing these measures, and you fatigue folks. But the truth is, we are at that point, from all indications we're seeing, where we're on an upward slope enough that we know, and with the lack of PPE and other things we're taking into account, that moving now is disruptive. It's going to be disruptive because we're going to get there anyways. And the sooner you go, and if you do them together, that's the impact we're after. And we hope we do this well. We hope, again, we mitigate this and we see that drop. Whatever we do will help at this point, and that is what we're doing. Now, very quickly, this is my complex study of predictive analysis, the kind you do on a piece of paper. We know a lot about this disease, but as you know, our diagnostics have been slower, and with our testing, we were sending to the CDC. It took 5 days, but once we've had this testing, we're ramping up. We don't know, for epidemiologists, they have to look at a lot of things. We're looking at the early studies. We're making best guesses. We're talking to the experts who made the model. We're talking to our CDC colleagues. But we can assume a couple things. We can assume, from what we've been hearing, that there's a peak of maybe 40, in some circles, to 70%. I've heard numbers as far-ranging as that from experts about how much of the population will eventually become infected. We know a little bit about the R0, which is how much one case infects others. It's roughly estimated, again, these numbers will change, at 2.28. We assume, from some early modeling that we've heard on thousands of calls I've been on with thousands of experts. Again, I take the best data. I hear conflicting. I usually use the more cautious and conservative of the data. There may be a peak of this, again, guesstimate, still, the modeling is still working, of late April to mid-May. So we took that number backwards. We also know that there's a serial interval, which means this thing is doubling. I've heard as little as 5 days and as much as 7 days. So 5 to 7 days, we're taking 6. So we have guesstimated a peak, and we went to mid-April. We said 60% infection. We worked our way back by the weeks, and we came back to what would 1% be. We roughly guesstimated March 9th. And our population, I have 11.7 million Ohioans as my patients. And we said, we know we have community spread. The data that comes out today will clearly show that these cases don't have a connection to anything we can point them to. We know that we have ICU patients. That's a big trigger for these interventions. We do not have a death yet. We know deaths often lag hospitalizations by 3 to 6 weeks. So even in South Korea, even in Italy, a lot of the data is still behind. And so we used all of that. I think the LG and I, he helped me say, what's 1% of 11 point, no. But so we are saying, I'm not saying there are absolutely for certain 100,000 people. I'm saying I'm guesstimating. If I'm guesstimating community spread, that's my best number. And without that data, as the data comes in, as we have it, as the scientists learn more, as modelers far smarter than I am, put that together, we'll look back at this and we'll see where we were. But so that is that answer. I want to say in closing, as I've always said about public health, the hard thing about this, we're working so tirelessly with our hospital system right now, but everything I learned in med school is just such a small part of all this fabric of things, from childcare to what we do in businesses. All of these things affect our life expectancy. They affect our health and well-being. 2/3 of these things that we have to solve collectively affect us. And so we're moving as best we can along with our fellow states, and you'll see it as best as each state can move given their unique circumstances. Those 2/3 of levers that we do, but 1/3 will be up to you. And so much will depend on us as citizens. We promise you the best information that we know as we know it. On our website, coronavirus.ohio.gov, we will keep posting things. you will see whole new worlds about what we do together. I know there are Facebook groups already deciding things. We know the most vulnerable are at risk. These decisions are not made lightly. They are not made lightly. We talk policy. Most of us have not slept a ton. We are talking policy walking here. We'll start talking policy on the way out. None of this is made lightly. And I just really want to say to our teachers out there, one last thing. I was asked, teachers, you can still become a polling worker. Some of us, you'll see redeployment of whole workforces to help out in hospitals and do other things, much more coming. But teachers, you can actually train this weekend, and you can help out the polls if you're healthy. And we want to get people out to vote, voteohio.gov. Thank you.
Questions?